All right, you want to get this quiz out of the way? Let's do it. There's your password. I brought a couple paper copies just in case too, so let me know if you're not able to get in. You snooze, you lose. 5 minutes is up. It looks like I have about 70% of your uploads. So go ahead and connect to the internet, get those going. Is this the point that I should turn around and you guys leave if you need to leave, if you weren't planning on staying? Or do you feel so awkward right now that you're not going to get up and leave? I'll just take it as a compliment that you're staying. All right, so I've posted my slides. There are, I think, 99 of them for us to cover over the course of 4 hours, which is really not too bad, 25 an hour, considering quite a bit of it at the beginning is review. So a lot at the beginning is review. So I'm going to trust that you know how to review what you don't know. We'll do a few little questions so you can kind of gauge where you're at today, just for fun, not for quiz. And then I fully anticipate you'll have to go back and look at some things from Patho, just because like this is hard stuff. Like the heart is hard, but I think the hardest part of cardio is arrhythmias, in my opinion. It's honestly my least favorite part. I'm like, give me hypertension, give me heart failure. Those are really fun. But this is kind of difficult stuff. So I'm going to try to point your attention to the things that you should look back on, but I will leave that to you to really just kind of gauge what you need to do. But first things first, most important things are baby pictures, right? So a few things have changed since I've seen you last. Let me see. I'm using a different iPad, so let me make this work. Oh, it ruined. You saw it. Okay, so here's my boys. So Jack is our baby. Y'all like the front lights off? Dr. Karbowski says. Heard a yes and a no. At least turn those off. Too much? That's good. Okay, we'll try it. We'll try it. So Jack is my baby. If you can tell, he has blue eyes, kind of lighter hair than brother. And then Luke is our 3-year-old. So Luke just turned 3. Jack just turned 1. Because I had just had Jack, like within a few weeks, I think, when I saw you last time. And then there's a cute little picture. They did that on their own. Like we have the photographer there. I'm like, please tell me you captured that. And she said, yeah, we got it. So that was totally spontaneous. But then here's baby Lucy that will be joining us. Isn't that cute? Like she's got her hands up. She was playing peekaboo with us. So she will be here in January. So 2 boys and a girl. Not going to lie, a little nervous about the girl. I feel like I can handle boys. But we've got Luke, Jack, so an L and a J, and then we're calling her LJ, Lucy Jane will be her name. So we like L's and J's, apparently. So, yeah, it's going to be a good lecture if you can start with baby pictures, right? So just to remind you, a couple of things. You guys know I like to use active learning because I think that sticks with you a little bit better than me just talking up here. I'm going to try to give you some real life stories of patients who are on these drugs so that you can remember them a little bit better than just memorizing what's on the page. So if you're fun with me, I'm going to be fun with you. I promise to always give you my all. Although I was up quite a bit with a sick baby last night, so you might have 109, but I'm bringing you all I got at this point, I promise. But my expectations should be very clear, and you should know this from the Patho exam as I test from the learning objectives. And you'll see there's learning objectives kind of for each section, not necessarily every hour of lecture, but kind of each section as we get to it. So if you use those to create a study guide as you go, you should be in really good shape for the exam. So my philosophy on pathophysiology, pharmacology, pharmacotherapy is that you received the base of pathophysiology last year we are building the soil, which is pharmacology, the medicinal chemistry, which ultimately is going to blossom in your pharmacotherapy knowledge. But if you are weak on either of the two bottom ones, obviously we can't have the pretty flower for pharmacotherapy of how you actually apply these drugs. So I'm going to try to give you that review of the patho. I'm building the soil, which is the pharmacology today, and then also on Wednesday, so that hopefully when Dr. Lamb gets here next week, he has really fertile soil and he can grow the pharmacotherapy and how to actually use these drugs. But when it comes to pharmacology in general, I feel like you are just looking at this expanse of stars. There's so many drugs, there's so many mechanisms, adverse effects. How in the world do you remember it all? Well, if I can teach you how it works, how to understand, then the details fall into place. So I'm really going to try to teach you the why of these drugs so that you can memorize the few little details that you need to. But very broadly, if you understand action potentials in the heart, then you should be able to see how these drugs work pretty clearly. So, are you going to make me proud? Okay. So SA nodal cells, we're not talking about ventricular myocytes, but in SA nodal cells, phase 0 is the upward movement. Do you remember what it is? Okay, I'm hearing calcium. In or out? Calcium in, very good. Okay, now we're switching. Ventricular myocytes, remember this had the different type of action potential. It looked more like, let me pull up my pen. Uh-oh, there's a little bit of a delay. There we go. Remember that one looks a little more like that? That's actually very pretty. Phase 2, 0, 1, 2. Got a balance of B. All right, let's look next. We linked what was actually going on in the heart to how we see that on an EKG. And actually, Dr. Carbasi just told me that you guys have had a little bit of a review on the EKG. So which one is not matched correctly? Here's C. Anybody else want to venture out? It's not C. We'll come back to this one. How about I'm going to ask you these same 3 questions. Make sure you get it. All right, so learning objectives, these should be the same from Patho. So if you kept your study guides, look through those. And then this is where I'm just pointing out key slides. So if you want to go back to your Patho notes and star those or whatever, these are just key slides that I'm bringing forward because I think they're still really relevant as we add on the drug therapy. So we filled that in Patho. Really important that you understand that electrical path, okay? So we're starting in the SA node. Those are the pacemaker cells. That's where we have our automaticity. Those cells should initiate an action potential that spreads throughout the atria, which are the top portions of the heart. Then those go through a gate. All those impulses come together, and there is only one way to make it from the atria to the ventricles. And what's that gate? The AV node. AV, atrioventricular node. That's how all those signals should go in through the AV node at one time. You should think back to why there's a brief delay at the AV node, because it takes a second and it has a pause, a 0.15 second pause before then that action potential travels on to the ventricles. And then very, very quickly in the ventricles, that impulse is spread so that we get a really good contraction together in the ventricles. So look back over that pathway if that's a little bit foggy. This is a good picture of the heart here to show the SA node up here where everything should be, hopefully, is originating. And you can see what that action potential looks like. So it's more of a smooth action potential here. But then when we get down into the ventricles, this is more of the action potential that we're focusing on, and that's the one that we drew, so the ventricular myocytes. You will need to know those phases, so I pointed those out to you. Does this look familiar? Yeah, you're like, yeah, I studied this quite a bit last time. There will be some questions on it. It's not going to be a huge focus, again, because I'm expecting that this is review for you. But I would look at both of these slides again to know, obviously, the phase, but then also the characteristics, what's happening, what ions are moving in that underlying current. Now, this is something to look at because, so we're looking at a ventricular myocyte action potential. That's what's in the red there. You can see that's when the actual response is being propagated, but the contraction of the muscles that's actually happening afterwards is a little bit delayed and is a little bit longer. It lasts a little bit longer. That's going to summate into what we call a refractory period. This is a good thing because in other types of muscle that are not cardiac muscle, you can get tetany, right? To where you just don't have relaxation. That would not be a good idea in the heart, right? Like you will die if there's tetany. So these muscles actually cannot have tetany, and it's due to this refractory period. So it is a time that even though you might have another action potential that's being propagated, there's a period of time where the muscle will just not contract anymore, which is a good thing because we have to have the heart beat and we have to have the heart relax in order for it to fill with blood and do its job. So the text there just describes that. Now, this seemed to be the question that we got stuck on and maybe should look back at a little bit. This is how all of the action potentials in the heart summate to what we can actually see on an EKG. So that P wave is the atrial depolarization, or we would call that the contraction, when the atria is actually contracting. Because what an EKG or ECG, whichever you say, I usually use the K, just because the team that I worked with usually used a K. But either way, back and forth. You have that contraction that's happening in the atria. So we're looking at muscle contraction. That's what's picking up on an EKG. Usually just a single little action potential that's gone awry will not be picked up on an EKG. So we're seeing huge atrial contraction in that P wave. QRS is the huge ventricular contraction, right? That's why it is so big, because most of the heart is the ventricles and you're getting a really good pump there. And then the T wave is ventricular repolarization, or diastole, when that relaxation is happening. So of those first three waveforms that we're looking at, we have atrial depolarization, ventricle depolarization, ventricle repolarization. I'm missing one. What are we missing? Atrial repolarization. When is it happening? It's hidden by the QRS complex. Excellent. So that stuck from last time. Happy to hear that. Then what we're looking at, if you look for these last three terms here, is really what measurements can we get. So from P to R is really the time that it takes for that impulse to go through the AV node, right? Because we've contracted the atria, and then QRS, we've contracted the ventricle. So the time in between the PR interval would be the delay at the AV node. So there's going to be some drugs that we want to increase that delay. So we would see an increase of the PR interval on an EKG. That is one of our ways that we can help with arrhythmias. QT interval. So from Q, which was contraction, all the way through the end of the T wave, which is that repolarization, that's going to basically tell us the whole action potential of the ventricle. So it's the contraction part and the repolarization. The whole ventricular action potential duration is seen in the QT interval. There's a lot of drugs that are going to mess with the QT interval. In fact, when we talked about it last semester, you guys had really not heard QT prolongation before. It was kind of the first time that you had heard that term. Have you heard it since then? in the last year? Have you heard more about drugs that cause QT prolongation? It's definitely a red flag to look for. If you work in a pharmacy, it probably pops up on your screen a lot, and you're like, ignore, like next. But this can actually be fatal, because if we prolong that action potential too much, then we can get something, there's a little, I guess it's a French word, somebody remember what it's called? Torsades, which is life-threatening. We'll talk more about it. And then ST segment. So it's the end of contraction going to when repolarization starts. That's actually the plateau phase, or phase 2 of the action potential. The plateau phase, that's unique to cardiac myocytes, okay? Not any other muscle has that plateau phase. You told me it was the balance of calcium and potassium already, so that was fantastic. But that's the plateau phase. So ST segment, you've probably heard more about STs in the last year too, right? ST segment elevation myocardial infarction, we call that STEMI, versus a non-ST segment elevation myocardial infarction, or an NSTEMI. So different types of heart attacks based on how the ST segment moves. So this is putting all of those action potentials together. I really like this picture because it shows how they all summate down to this bottom, which is what we're looking at. But it shows you how each of the action potentials, which we're focusing on SA node, as well as it's really this endocardium, this ventricular endocardium, what that looks like. Okay, so actually you did good on those first 2 questions. So since I spent a little bit more time talking about this one, tell me what are your thoughts are now? So again, it's which one is not correctly matched. I'm hearing more A. Good. A would be the correct answer here. So let me say, guys, I'm actually impressed. I really am. I saw some head nods as we were kind of going quickly through the review. So hopefully you're feeling good too, but I feel really good. Okay, so there were some references for that first section. That only took us like 2 hours last year, and we just did it in, 15 minutes. All right, so now I want to review arrhythmias, because obviously I'm about to tell you the drugs, and so we need to know how that relates back to arrhythmia. So this might be a little bit more foggy than the first. So arrhythmias, you should just think electrical dysfunction. Electrical dysfunction. Heart failure is more of a mechanical dysfunction, like the actual muscle is not pumping the way it should be. But arrhythmia just means something is wrong electrically. Can you think of maybe some ways how this happens? Maybe some disease states that lead to it? I mean, where are some causes of arrhythmias? Okay, so electrolyte disturbances. I heard hyperkalemia, actually hypo or hyper. Other electrolytes that you think could get off and affect the heart? Sodium. We've already said potassium. Calcium, right? Basically all the ones that are involved in the action potential. If we mess with those levels, of course, that's going to change action potentials. Magnesium is the other. Even though it's not directly involved in the cardiac action potentials, it affects other electrolytes, which can. What are other potential causes? Ischemia, okay, so myocardial ischemia. So that could be, when someone is exercising and they're not getting enough blood flow to the heart, maybe you have a little bit of atherosclerosis. So not a heart attack just yet, but it could lead to a heart attack. Do you think a heart attack could cause electrical imbalances? Yeah, because if you have part of the heart that has died, right, that's basically what an infarct is. You're not getting blood flow to a certain area of the heart because you have like a blood clot, basically, from atherosclerosis. So you have this section of your heart, this muscle that is dying. Well, that can't transmit electrical impulses. In fact, it messes up all the tissue around it too. If you have one little piece that's dead, then everything around it starts to mess up as well. What else? Do we make arrhythmias? As pharmacists, we make arrhythmias when we give certain drugs, right? Certain drugs will cause arrhythmias. In fact, I can't remember if I told you this in patho or not. All antiarrhythmic drugs cause arrhythmias, okay? They're arrhythmogenic. All antiarrhythmics are arrhythmogenic. So that's fun, right? We correct one just to make a different type of arrhythmia. Let's see. Hypertension and heart failure can both contribute to arrhythmias, and none of our patients have those disease states, right? So a lot of potential causes for arrhythmias. So I've got your learning objectives. Again, those were the same from patho. This would be your broad slide to remember the different types of arrhythmias. So we have those after depolarizations. We call those triggered activities because those happen once you've already had an action potential. Okay, so they're coming off of an already existent action potential. I skipped altered automaticity. Altered automaticity could be for a good reason, like you're exercising and so your heart rate changes. That's a good thing. Or it could be abnormal. It could be when you have other pieces of the heart that are not the pacemaker cells that decide, I think I'll be a pacemaker today. I'm going to start beating differently and see if the rest of the heart will follow my lead. Okay? So that could be, or usually always is, a bad thing if others start to follow. And then reentrant arrhythmia. So we talked about, this is called circus movement because literally there starts to be a circuit that happens for electrical activity. So instead of that activity going from the atria down to the ventricle, it gets stuck chasing its tail. And so you just have action potentials that are going in a circle. It can be anatomically defined, and we talked about Wolff, Parkinson, White, but it can also be functionally defined. This is when you just have a part of the heart that's not working. Could be due to an infarct, could be due to ischemia. But we'll break down each one of these just a little bit more. But that, to me, that's kind of the broad outline of everything. Now we're digging into each one separately. So altered automaticity, again, you've got just some enhanced normal automaticity, but then you've got the abnormal as well. So it could be that your cells that normally can display that spontaneous depolarization, that they just go a little bit crazy. So maybe the SA node starts beating faster than it should, or maybe the AV node steps up and says, you know what? SA node, you're slacking. I'm going to create our new rhythm. And even the His-Purkinje system, so that's in the ventricular conducting system, it can even decide that it wants to start some impulses. So that would be enhanced because all those cells are capable of producing an action potential on their own, but usually they follow a hierarchy. So the SA node rules most of the time, as it should. Do you remember why? Do you remember why the SA node rules and why most everyone follows the SA node? It's the fastest, right? It's like 60 to 100 beats per minute, so it's setting the pace. Then the AV node could, if it needs to step in, it's going to be at a little bit of a slower pace, but it's there kind of as a backup if we need it to. And then the His-Purkinje system, it's going to be pretty slow if it has to go in. I think it's 30 to 40 beats per minute. It'll be a while. Let me give you those numbers because I know you want them. So it is 60 to 100 for SA, and that's beats per minute. 50 to 60 for the AV node. And if the His-Purkinje system has to, it's going to be more like 30 to 40 beats per minute. All right. And then the abnormal automaticity, this is where cells that should not be, it's none of those cells, it's just other extra pacemaker cells start to depolarize on their own. We see this a lot when there is ischemia present. So that's automaticity. It's doing it on its own. It's automatic. A couple of other types of altered automaticity, you could just phrase these different ways. There's physiologic and also pathologic. So again, we're both describing altered automaticity here, except we were talking more about the sites before when we were looking at the enhanced or the abnormal. Here we're thinking more of, is it physiologic or is it pathologic? So just different ways to describe the same thing. You can read back if you want to look at escape beats and ectopic beats. But here's that direct tissue damage that could happen from myocardial infarction. Basically, you lose those gap junctions because the muscle has to very, very quickly propagate that action potential. And so if that ion gradient is changed or if those gap junctions are lost due to some sort of damage, then you're not going to be able to have good propagation. Okay, now after depolarizations, you probably remember the DADs, and the EADs. So delayed after depolarizations and early after depolarizations is how we describe those. But basically they are arising from an action potential that has already happened. So you have probably an initial normal action potential that triggers a second one to happen. And we looked at these visually, and again, you can look back over these and read some of the details. But if we're doing this in a ventricular myocyte, then a normal action potential we would think is going to look something like this. But a delayed after depolarization, I'm going to flip it over to red, would be if something is arising and we have another action potential that is coming off and it shouldn't be coming yet. So it's delayed. It's probably happening in phase 4. But it's not normal. It's arising probably from that resting potential down here at phase 4, which you know is your baseline, phase 4. And do you remember if it's exacerbated at fast or at slow heart rates? This one's fast. Fast heart rates, usually from too much calcium. And I can't remember last year, there was one class, I can't remember if it was your class or if it was the current P3s. The way that they remembered this was with DADs, the delayed after depolarization, they're always filling up bottles, right? Milk. At least that's how it works in my house. That's Dad's job. I feed the baby, but he gets the milk ready. So maybe you can remember it that way. And then the early after depolarizations, let's switch back to blue. It's going to happen a little bit sooner. So this is that phase 0 upstroke, phase 1, we're starting to repolarize. We're getting down into the plateau phase. And then see if we can turn to red. Then we're triggering some other action potential. This is probably arising from phase 2 or phase 3. This one is the, I guess, extra scary one because it could lead to torsades de pointes. And all drugs, even like cancer drugs, gout drugs, whatever, all new drugs are tested to make sure that they don't inhibit potassium channels to lead to torsades just because it is so life-threatening. And it's just the opposite. It's usually at the slow heart rates. All right. So now let's think about reentrant. So these are the ones that just get stuck chasing their tail, basically. So you've got the anatomically defined reentrant. arrhythmias, but then also the functionally defined. So here's the difference. Anatomically defined, it's when you actually have a reason in the anatomy of the heart that it gets stuck in this arrhythmia. Do you remember last year we turned the room into a heart? And we passed some paper towels across. That was supposed to be the fibrous tissue that separates. We had atria up front, ventricles in the back. And that paper towel was supposed to be a fibrous tissue that action potentials can't get through, except in one spot. And right in the middle, we separated it. And that was the AV node that impulses could get through the AV node. But I came over to this side, and actually, was it you, Renee? Because y'all are kind of all sitting close to the same spot. So somewhere in this area, I made a second hole in the paper towel. And that is anatomically defined. So there is something wrong with this structure. It is anatomical. Now, there are two ways to get through that fibrous tissue that should not be propagating an action potential. And in that case, what can happen is the action potential, like it should, goes through the AV node, spreads through the ventricles, through the bundle of His, and then the Purkinje fibers, except instead of it stopping and bouncing off that wall, just comes right through that gate. And then it is straight going back into that AV node. And so now we've started this circular movement here. It's anatomically defined. That is Wolff-Parkinson's White. It is a pretty rare, in my practice, I've seen 2 people with Wolff-Parkinson White, so it is pretty rare, but it is an anatomical issue with the heart. Functionally defined is really just when peace, to me, I think of it as a click. I think that's how I described it to you last year. It is a click that, let's just say these 4 people right here, you say, you know what? This is a great group of people. Let's just send this action potential back around. So instead of it going where it should, it stays here. Now, the rest of the heart is still functioning, right? So they're still sending their impulses, but you guys are having a little impulse and a contraction every now and then too. Which what that means is if you guys decide to do it, well, maybe you get tired of these 2 people participating and you say, you know what, let's turn around to our friends in the back. And you start having a little it's called a circus entry. So we have a little circus going on here. This one moves, the second one, the functional one. It's not like it gets stuck like we did in that particular hole earlier. It just kind of moves around. So it's probably going to stay in the atria or stay in the ventricles, hopefully in the atria. If you have an arrhythmia, which one do you want? You want an atrial arrhythmia. The ventricle starts going crazy, that's when we're not getting blood pumped to the rest of the body. So give me an atrial arrhythmia if I have to have one. But this one starts kind of circulating around. Hopefully it stays in the atria, because what we can do is, first of all, we can just zap you. We can be like, boom, quit being friends, separate. It's like the teacher coming in and separating the class, okay? So we do that with ablation. We can actually go in and radio frequency or even cryoablation, stop that from happening. Or what's another potential strategy? The atria starts going crazy up here. What can we do? Because we don't want it to reach the ventricle, right? If it gets to the ventricle, that's when people die, okay? So how do we keep the circus up in the atria? What? Well, antiarrhythmics would be the word. Antiarrhythmics. Do what? Calcium channel blockers, yes. But why? That is the correct answer, but why? Okay, so we've got one gate, right? There is one gate, one way that action potentials can leave the atria and go to the ventricles, right? How about we strengthen that gate? Let's make that gate as strong as it can be. We're actually going to probably slow propagation through the gate so we can be a little bit more meticulous about what comes through. But if we can make that gate stronger, then we can stop the craziness from getting to the ventricles, which is really important. Calcium channel blockers are one of the drugs that'll do that. Yep.
For the functionally defined ones, they can move around, but you said that like we can zap them like surgically, so to speak.
Mm-hmm.
So is it?
If we can
like
tell that
we can just stop. It doesn't matter so much the cells
Yeah.
themselves, but like the fact that it's happening, and that's
So
how that works.
it depends. If it is localized and we know where it is, then it can be zapped. But often it is not successful because just because we fixed one click doesn't mean another one can't pop up. So often ablations are not successful unless in certain situations. So sometimes young kids will get a type of arrhythmia that's really easy to use an ablation on, and it works usually for the rest of their life. In adults, it's usually not as effective for ablation. But if we can localize it and figure out where it is, then ablation could be better than taking drugs for the rest of your life that cause arrhythmias. Yeah, Daniel?
So you said calcium channel blockers strengthen the AV node?
Well, we're going to talk about it a little more in depth. That's kind of a simplistic way of thinking about it. But they are going to make it to where only the signals that we want get through the AV node, usually by slowing the heart rate. Okay, so do we see the difference in anatomically defined reentry versus a functionally defined? Okay. There it is if you want to kind of read through and look at it visually. Let's see, I think we've talked about everything here. Kind of got stuck on that picture that I really liked. You can read through about WPW. So these functionally defined or reentrant arrhythmias, these are our fibrillations, which is really what's most common. So examples here would be atrial and ventricular fibrillation. So read back through this. This is nothing that you haven't already seen before, but just pointing out a few things for you. All right, so Dr. Karbosky may have you memorize different pieces of an EKG as far as making a diagnosis based on the tracings. I'm not going to have you do that here, but you could work through and kind of think in your mind what this looks like on an EKG. But what I want to point out to you is these different types of arrhythmias and how they come back to the after depolarizations or the two different types of reentrant tachycardias. So you've got your normal rhythm there. That looks nice. A premature beat can happen. So this is just when part of the heart just says, hey, I'm going to just have an action potential and let's see if anyone else follows me. And maybe for a beat or two, you do have most of the heart that follows, but it usually just goes away. Just a little palpitation. You may feel it, you might not, but just a little premature ventricular beat. This is actually really common. 25% of the population has this sort of premature beat. Which type of arrhythmia do you think it is? Well, this is a ventricular beat because it's at the QRS. Is it altered automaticity, which could be enhanced or abnormal? Is it after depolarizations, which could be early or delayed? Or is it reentry, which could be anatomical or functional? Abnormal automaticity is what we see here. This is just a little piece of the heart deciding to try to be the SA node. So this would be an abnormal automaticity. Okay, PSVTs, paroxysmal supraventricular tachycardia. Let's break down what this word means. What does paroxysmal mean? A little bit louder. Paroxysmal. Have y'all learned paroxysmal nocturnal dyspnea yet? No, Pandy. Paroxysmal just means comes and goes. It's intermittent. It's not continuous. So it comes and goes. It is supraventricular. What does that mean? Above the atria, right? So just above it. And fast. So we're having this intermittent atrial tachycardia. Atrial. It's supraventricular, so it's above the ventricles, so it's atrial. This is a type of re-entry, actually. It's usually anatomic. Usually there's a reason for this one. So I'm going to put anatomic, sorry, I'm abbreviating these, re-entry, anatomical re-entry. So you can think of PSVTs and Wolff-Parkinson's White as being similar as far as there's some sort of anatomical issue going on. Okay, we've said the fibrillations are what type? Functional reentry. Yep, this is going to be the most common type of arrhythmia that you are treating. So I'm actually going to do it for, so there's atrial fibrillation, there's atrial flutter. It even shows another type of atrial flutter here. Basically, you can't see P waves is what's happening. Why do you think that is? So I heard it's happening so fast. So let's think about what atrial fibrillation would look like in this room if we were setting it up. Atrial fibrillation. This would be that functional reentry. So we've got a tornado. Actually, Audrey, I like your your analogy there. So we've got these little circuits that are all going in the atria. So that is electrically what's happening. What are the muscles doing? If electrically we're sending all these little action potentials, what are the muscles doing? Do you think they look like this or like this? Yeah, give me your little worm fingers here. Yeah, this is what would be happening because there's so many action potentials. The muscles are like, oh, maybe I should contract, maybe I shouldn't. And so you just get this irregular beat because it doesn't know what to follow. That's the fibrillation. It's sometimes described like worms. It's fibrillation. So we're not really seeing a good P wave. Why is that? What is the P wave on an EKG? It's that atrial contraction. So if we have a good contraction, we see a good P wave, right? It's a good little blip on the radar. But if every muscle's kind of doing its own thing, we don't get that good, strong P wave. So that's why it just kind of looks little. There's things there, right? But just not much is happening. We don't get a good, strong P wave. So functional reentry when it comes to fibrillation and flutter. Now, sometimes the heart rate in atrial fibrillation could be normal. You're not necessarily tachycardic with AFib. Why would that be? Why could a heart rate possibly be normal in atrial fibrillation?
Because it all goes through that AV node.
Boom, AV node. If our AV node is doing its job, even though there's a lot of impulses that are happening, it's only letting one strong one get through every so often when it should, okay? That would be a good thing. So we could have a normal heart rate. It doesn't necessarily have to be tachycardic. Now, if the AV node isn't doing its job, then you could see some tachycardia with it. All right, the last ones here, these are all going to be triggered. Actually, I'm going to stop that line there. These are all the triggered or the after depolarizations. You don't want to see these on an EKG. This is like, these are very life-threatening. When they happen, this is actually the torsades. They call it a twisting of points. It looks like there's just a twisting that happens on the EKG line. So those are all after depolarizations. Particularly if it's torsades, it's probably from an early after depolarization. And then the last one, VFib, is obviously the ones that we don't want, but that would be a functional reentry as well. Except instead of it being in the atria, it's in the ventricles. Okay, I've got 10:51. You want to take a 10-minute break? Take your question when we get back, Zane? Does that work? Okay, we'll start back at 11. All right, well, let's go ahead and get started. Good, going good. All right, so reviewed arrhythmias. I think Zane had a question before we went on break. Do you still want to ask that one, Zane? Or no?
In this slide, is the amplitude of the waves indicative of the strength of ventricular contraction? My real question being, for the AFib patterns that we're seeing, they don't look nearly as large as the normal rhythm. So are you going to actually see any type of slow oxygen deficit over time with one of these? Or?
Yeah, so it's going to depend on the lead of the EKG. So the question is the amplitude related to the force of contraction that's there? Depending on the type of EKG that you're getting, right? There's different leads that are going to be able to read different things, then you could be able to infer some information from that. And a really experienced electrophysiologist is able to look at the different leads and be able to tell what's going on. Not even going to claim to be able to do that, but yes, depending on the type of EKG that's present and where the leads are placed. All right, so this chart is kind of the, I guess, summary of what we've talked about when it comes to the different types of arrhythmias. And I've left a column here on the outcome for us to think about what's going on. Is this life-threatening? Can we live with it? You know, what's up with the arrhythmia? So a sinus tachycardia, sinus just means it's in a normal rhythm, right? It's following the SA node in a normal rhythm. So that could just be an altered automaticity where the SA node is firing a little bit higher at a higher rate. When would that happen? Exercise. Adrenaline rush during an exam, right? These could all be normal things. So I'm going to say could be normal. We would want the heart rate to increase in certain situations. If it doesn't, that's another issue, right? If it's not doing what's supposed to be doing. PSVTs. Really self-limiting. Did I give you guys this chart last time? Boo. Okay, refer back to this chart. I'm not going to... Because I typed it all up and it was really nice. Yeah, so this is transient, self-limiting. This is sometimes what teenagers will get. And we can ablate because we know where the anatomical re-entry point is happening and we can fix things. My close member in my family, I guess I shouldn't say who, but a close member of my family had this as a teenager. So this is usually just transient and self-limiting. But we'll treat if we need to. Atrial flutter and atrial fibrillation are extremely common. It's just a really, really high heart rate, especially in atrial flutter, up to 300 beats per minute. Let's see, what do I have here for us to know? Usually radiofrequency ablation will be used for atrial flutter. Whereas AFib, you can have it for years and not even know it. So tolerated for years, that's what we'll put on AFib. What's the risk in AFib? Why do we treat it? Because this is one that we might not treat with an antiarrhythmic, but we are definitely going to treat with something else. Not hearing any strong responses here. Kari.
You would treat it with a blood thinner.
You would treat it with a blood thinner, an anticoagulant. Why? What's the risk?
Since the blood is not circulating through the ventricles well, you can clot.
Okay, so what happens is, remember up in the atria, we've got the not very strong contractions that are happening. So blood is not really being expelled from the atria very well. So blood loves blood and loves to stick to each other. You've got platelets that are in really close proximity to each other, and we call it pooling, P-O-O-L-I-N-G, pooling in the atria because it's not being forced out. It's not moving. It's becoming stagnant. Okay, so we've got stagnant blood in the atria that loves each other, forms a good little clot. And then let's say, hey, we're all of a sudden, let's treat their atrial fibrillation. And so now AFib is fixed and we get a good contraction. What happened to that blood clot? Now it's in the ventricles. Then it comes out and goes to the brain, causing a stroke. So we treat AFib with anticoagulants, usually before we're going to treat with the drug, like a drug to stop the AFib, so that we can make sure the patient is anticoagulated so that, first of all, there's no clots there to get expelled out because it will cause a stroke. I'm kind of a stickler for this. It is a pet peeve of mine. An anticoagulant is not a treatment for AFib. You are using an anticoagulant to prophylax for a stroke that could result from atrial fibrillation. So the anticoagulant is not an antiarrhythmic. It is preventing a stroke that could happen from AFib. So you're going to learn there's scores that we use. The CHADS-2 VAS score we'll use to calculate what is the risk of this person actually having a stroke and what type of drug, which type of anticoagulant should we use. Depending on how long they've had it, you're going to learn all this. But it's just so fun, and I hate to stop at the pharmacotherapy. But depending on how long they've had the AFib, we could just do a direct current cardioversion where we come in and go just like ER or Grey's Anatomy, whatever you watch. I just dated myself by saying ER, didn't I? So you come in, like literally direct current cardioversion. We pump their chest, resets the electrical activity of the heart. Now that does mean they come down to flatline for a minute, but then SA node kicks in. And then the rest of the heart starts following the SA node. That's what we want. But if we do direct current cardioversion, DCC, we're going to have to look and say, well, how long have they had this AFib? Because if they've had it for a while, there's a good chance that there's a clot in there. And as soon as we pump them with force, that clot's going to pump out at the same time. And so depending on how long they've had it, we'll send them home, say be on anticoagulants for a while, let's make sure there's no clot, then we'll come back and do a DCC. That was all pharmacotherapy. I just couldn't resist, okay? Forgive me. Okay, then all the ventricular stuff is pretty much fatal, very, very much life-threatening. Just being honest. Very much life-threatening, could be fatal, especially torsades, if not treated in seconds to minutes. Okay, so now we're getting into the drugs. Good review, too much review, too little review. Goldilocks, did I hit the spot? I'll take it. I will take it. All right, so now the drug part. Bad news is there's a lot of drugs. Good news is there's only 4 main mechanisms. Yep. Cool. So there's your learning objectives. Definitely look at those. But before we hop into the drugs, I think I might have mentioned this in patho to you. We don't treat all arrhythmias because we're likely to cause another arrhythmia. So if you can live with it, probably let you just live with it, depending on what the drug of choice would be for that. We've got a lot of non-pharmacological therapy, so we can give someone a pacemaker to make sure that their heart stays on the beat it should. We can do defibrillation, just like I said, like boom, we just direct current cardioversion to reset the electrical activity of the heart. We also have radiofrequency ablation. If we can figure out where those cells are that are going wrong, we will. But sometimes we can just correct the electrolyte disturbance, which is really easy. But we have to monitor these drugs really, really closely. All antiarrhythmic drugs should be a red flag drug to you because it will either cause another arrhythmia or cause some pretty nasty side effects. So all of these, to me, all of the drugs we're going to talk about cause a little flag to go up in my mind. So here's those basic mechanisms. Class 1, we call these our sodium channel blockers. It makes sense that if we're going to affect some sort of electrolyte when it comes to action potentials, probably thinking sodium, probably thinking calcium, probably thinking potassium, right? Those would be the 3 big ones that you're thinking about. Well, if you add beta blockers to those 3 that you already know, there's your 4 mechanisms, okay? We call this classification the von Willems classification. It's how we just group all of the antiarrhythmics together. It's not great. So, like, there's been talk of not using von Willems anymore for this classification because, number one, it doesn't include all of the drugs. So it's not all-inclusive because there's going to be a few miscellaneous ones that we throw in there and they don't really fit anywhere. And a lot of the drugs will have maybe two different classes that they go into. So we're going to put them in a main class, even though you might think, well, that's a beta blocker. I know Sotalol is a beta blocker. It ends in LOL. You're right, it is a beta blocker, but it is not class 2, it is class 3. The way that it primarily works in arrhythmias is by blocking potassium channels, which is class 3. So, funny joke over there? No? Oh, yes, it is. So, it's not great. The von Willems classification is not great just because it's incomplete. Some drugs don't fit into any of these, and then it's not pure. There's going to be some drugs that go into multiple ones. But I will tell you, Sotalol is a class 3 agent. Do not put class 2 on the exam. It's wrong. Even though it is a beta blocker, I don't care what resources you come back at me and say Sotalol is a beta blocker. I know it is a beta blocker, but it is a class 3 antiarrhythmic agent, not class 2. So let me show you the way I remember the mechanisms with these. So have I already showed you this? Okay, good. I still have some tricks underneath my sleeve. Okay, so class 1, that's just, let me do the other ones and then you can remember class 1. Okay, so beta blockers. B is the second letter in the alphabet. So B, number 2. Is that self-explanatory? Okay. 3 are agents that prolong the action potential. You're going to see that those are potassium channel blockers. How many strokes of your pen does it take to write a K? 1, 2, 3. If you write it like a kid, I guess. So it is class 3. And of all of the I's and V's that are here, which one looks like a C? It's got to be the 4, right? So the V, just look, it's a sideways C. And it's the only one. It's a sideways C. All letters and numbers at our house are flexible, we'll say. Like Luke, I'll say, what number am I holding up? A W. Like, yes, this is a W, but it is not a number. So, the V is a C. And then that just leaves the main one that you're probably thinking about, which is sodium. Because if you're thinking of the heart and action potentials in the heart, the first thing that comes to mind, for me at least, is sodium. So it's the number one thing that should come to your mind. So when I give you a drug, you should know which class it fits into. Okay? There's definitely going to be questions about it. There's going to be some questions that I don't tell you the class. I'm just going to assume that you know if it's this drug, it goes into this class. All good there? All right. So those are the 4 main classes. These do not equate with the 4 main mechanisms, okay? So don't try to align that the top one is sodium, the second one is beta blockers, third one is calcium. These are or potassium and then calcium. These don't align, okay? This is just in general how these drugs work. And actually they kind of all work in different pieces. So we're looking, what type of action potential are we looking at here? Is an SA nodal action potential or ventricular? We're looking at ventricular. Now, there are effects on the SA nodal action potentials as well, especially with sodium, calcium, and potassium. But here we're just showing what it looks like in a ventricular action potential. So a couple of different ways that these drugs can work. You can change the rate of phase 4 depolarization. So phase 4 is that baseline, right? It's the bottom line here. We can make that slope not so steep. It takes a little bit longer to get to the next action potential. Now let me show you what I hate about this figure. You would think that black is baseline and blue is added drug, right? It's not. Blue is the baseline, and this black, the second black here, and let me just add another blue into the mix, right? Here we'll go red. It's actually this second piece of black would be what the drug effect would be. So instead of the next action potential happening here, as it should, we can slow that rate of phase 4 depolarization so that action potential doesn't happen until a little bit later. Which is very similar to increasing the threshold. You guys know that for action potential propagation, there has to be a threshold that is met before it takes off. This is any type of action potential. So we can just raise that threshold. So kind of the same thing happens. Your action potential is not coming until later, but it's not so much the slope of phase 4 as much as it is the threshold has increased. Therefore, it takes a little bit longer to reach that maximum potential. Which is actually kind of similar to the maximum diastolic potential, but this is in pacemaker cells. So they're saying that in your SA nodal cells or in your AV nodal cells, we just increase the baseline. So that decrease the baseline. So the maximum diastolic potential, we just move that line down, which is really the same thing as increasing threshold, right? You kind of see that? If we move the diastolic line down, it's still going to take longer to reach threshold. So it's just those 2 and 3 are kind of the flip side of doing the same thing. And then lastly, we can increase the action potential duration. So this is actually spreading out that ventricular action potential so that the next one can't happen as quickly. So again, these are not necessarily tied to specific drugs. Like the first one, for instance, sodium channel blockers and beta blockers both have effects on A. So sodium and beta blockers. But sodium and calcium channel blockers can both change that threshold. Adenosine is a specific drug that decreases that diastolic pressure. And then your potassium channel blockers and your beta blockers can both have some change on the action potential duration. Mostly potassium's what I'm going to think of though. So again, these are not linked to class 1, 2, 3, and 4. These are just general ways that these drugs are working. Now, I'm going to skip a couple of slides. I think it's 2 slides. I want you to go back and look at these, but I want to get into the drugs first, and then I think these will make more sense. So this is for triggered activity. So your DADs and your EADs. this is kind of our thought process through treating these and why certain drugs work and certain drugs wouldn't work. So again, I'm going to hold this because I think it might not make as much sense if we do it here at the beginning. For reentry, this is kind of our thought process here. I would definitely star that these three classes of drugs here are going to be the ones that I refer to as the AV nodal drugs that are going to make that AV node strong so that it only lets through the action potentials that it needs to let through. So calcium channel blockers, beta blockers, digoxin will also do this. And so if we are trying to make that AV node more effective, then those are often some of the drugs that we'll use first. But it's going to break down reentry to anatomic. And then remember, anatomic was our Wolff-Parkinson's White, paroxysmal ventricular tachycardias. And then our functional were more of our fibrillations and flutters. Okay, so we will get into specifics, but let's do an overview of each of those categories. So sodium in the Vaughan-Williams classification was class 1, because it's the first thing that you think of. And this is really how it works. So I would say those first 3 bullet points are like a mechanism of action for you. Now, within the class of sodium channel blockers, we have 1A, 1B, and 1C agents. So they act differently. So we're trying to make some sweeping generalizations of all sodium channel blockers, but you do have 3 subclasses within the greater sodium channel blockers. But this is really how it's going to address different types of arrhythmias. But you know that sodium plays a role in both the SA nodal cells with those funny currents. The funny currents are carried mostly by sodium. And then in your ventricular myocyte action potentials, which phase of the ventricular myocyte is attributed to sodium moving inward? The upshoot or the upstroke, which is phase 0. And phase 1 is when it starts to come down off the action potential. That's usually where the sodium channels are inactivated. So it makes sense that they work this way. It can decrease that slope of phase 4. So that's in SA nodal cells because that's mostly attributed to sodium. Those funny currents are sodium. And we know it's abnormal automaticity. We're talking about the, we're talking about SA nodal cells here. But it can also decrease that triggered activity. So your EADs and your DADs, because those had to do with sodium, right? So both of those could be involved, or sodium channel blockers could treat those. And then it can also work for that anatomic reentry to try to slow conduction through that site. So over by Renee, where we split the hole in our fibrous tissue, we could slow conduction down through that by using sodium channel blockers. Now, I guess a problem is that it can exacerbate functional reentry. So it can help with the anatomical reentry, but it can make functional reentry worse. And it's really what we see in the second bullet down here. So I'm going to connect those bullets together. So when you have like a myocardial infarction, part of the heart is dying, that's usually where we can see a reentrant ventricular tachycardia happen, because there's a piece of dead tissue in the middle, and so this circuit starts to form around that dead tissue. And that happens in the ventricle, which is usually where the infarction is going to happen. Then that is definitely a problem. Sodium channel blockers can make that worse. So much so that there are trials. It's actually the CAST trial. So there's certain landmark trials that you kind of know their names and what it means. CAST is one. And the CAST trial said if you use a sodium channel blocker in someone who has had a heart attack, they are 2 to 3 more times more likely to die. Bad odds, right? So you have an increased mortality of 2 to 3-fold if you use a sodium channel blocker in a patient that has already had a heart attack. So next up, beta blockers. You already know a ton about beta blockers, right? I was telling someone the other day that to me the hardest thing about cardiology is that it's the same drugs, but they're used in different disease states for different reasons, right? But it's the same drugs over and over again, like beta blockers. Even though they're not first line in hypertension, they're used in hypertension. They're used in ischemia and infarction, right? And that's going to be one of the things that we give them as soon as they get to the ER. It's used in heart failure. Paradoxically, it's used in heart failure. You're going to figure out why. It's used for arrhythmias, but it's all for a little bit of a different reason. So what I'm going to focus on here is not so much that you know all the beta blockers, because you probably do. They're kind of easy to spot. But that we focus on why they are used in arrhythmias or in particular types of arrhythmias. So beta blockers and calcium channel blockers, I'm assuming you get a lot of that in a whole lot of other sections. So we will put our focus on why arrhythmias. So beta blockers here, I just remind you what beta stimulation does. Where are beta receptors located? Beta 1 in the heart, because you've got one heart. Beta 2 mostly in the lungs. That's my picture of the lungs. Because you have 2 lungs, right? It's also in the arterioles, in your blood vessels. It's where beta 2 is. Normally, if you stimulate, so this is stimulation of a beta receptor. If you stimulate a beta receptor, then it's going to increase calcium. That would increase the heart rate, right? Which would shorten a PR interval. But if I'm thinking beta receptors in the heart, I think 2 things: increase heart rate and increase force of contraction that has to do with that calcium there. So if we give an antagonist, which this is our class 2, because B is the second letter in the alphabet, our class 2 agents, it does the opposite, right? It's going to decrease heart rate. If we're decreasing the intracellular calcium, that's also going to decrease the force of contraction. And that could help in some of those after depolarizations that are going on, because remember, especially the DADs, it came from there being too much calcium, right? DADs filling up the bottles with too much calcium. So, what does this matter in arrhythmias? They are going to increase AV nodal conduction time, meaning it's going to take longer for that action potential to make it through the AV node. This is why beta blockers are one of those classes of drugs that make that gate a little bit stronger. It gets a little more picky. I kind of think of them as a bouncer. Only certain action potentials are going to make it through. Not every single little one that comes its way. It's only going to send through what it should. So it's going to increase that conduction time. So it's going to take a little bit longer to increase the time that action potential actually makes it through. So that's actually really good. If there's a reentrant arrhythmia that involves the AV node, like in Wolff-Parkinson-White when it got stuck in that same little movement, well, that's a good thing. If we have made it to where not all action potentials make it through, then we might be able to terminate that arrhythmia just by stopping a few of them from entering. Plus, the other reason why that's really good, so I think this little bullet point's pretty important. The other reason why beta blockers are good is that it controls that ventricular response to all the craziness happening in the atria. So if you have atrial fibrillation or atrial flutter, and you're hitting the AV node with hundreds of action potentials at once, the AV node says, you know what? I'm going to take my time. I'm only letting certain action potentials through. It's going to take a little bit longer to get through, but we're going to slowly let them happen. Then that way, the crazy reentrant tachycardias don't get through the AV node to the ventricles because we're really trying to protect the ventricles. So beta blockers are good to control that ventricular response to an atrial fibrillation or an atrial flutter. Does that make sense? Also, and you probably already know this, beta blockers are really good if there's some sort of physical or emotional stress that's happening. This slows down your sympathetic response, right? So that's why beta blockers are banned from the Olympics. There's certain types of sports like archery or any type of target where you are trying to be very still. Well, you're in the Olympics, you're shaking, right? Your beta blockers will stop that response to any type of emotional stress, right? You're not going to be shaking. You're not going to have that physical response to the emotion. So beta blockers are helpful in that. If I have an arrhythmia, I hope it's treated with a beta blocker or a calcium channel blocker, okay? Like these drugs are not as bad as the sodium channel blockers or the potassium channel blockers. So just some general concepts with beta blockers. Let's look at some general concepts now with potassium. Potassium channel blockers should definitely be red flags for you. A lot going on here. So if you block a cardiac potassium channel, that's going to increase action potential duration. And let's think why that is. If we've got an action potential, and we are blocking potassium channels, I have just prolonged that action potential, right? Because I'm not letting potassium move to have that repolarization to come back down for the next action potential to stop or to start. So we call this an effective refractory period, or the ERP, because another action potential can't happen yet. During this time period, another action potential, even if it comes through, there's not going to be a response from the cardiac tissue to that action potential. So we are drawing out that action potential duration, which would reduce normal automaticity, right? You're not going to be able to have another beat come in. So that is your action potential duration. Actually, I just realized that bullet 1 and bullet 3 are a repeat of each other, but you need to know that that increases the QT interval. What was the QT interval? Beginning of QRS to the end of T is your whole ventricular action potential. It is your depolarization and your repolarization. So it's a whole thing. So that makes sense, right? If we just stretched it out, that's the same thing as stretching out the QT interval, right? You see that? I'm going to say that one more time. This is important that you understand this concept. If we are stretching out that ventricular action potential, that's going to make the QRS complex a little bit wider. It's also going to make the T wave a little bit wider. So now our QT interval, if we count the time from Q to the end of T, we've just increased that space. And it's going to be a while before another action potential can come because we've increased that effective refractory period where another action potential can't happen. So there's that refractoriness. This gets a little bit risky because you're basically saying, heart, you can't beat during this time period. And you're going to hope that the next one comes when it's supposed to, right? Because we just stretched it out and said another beat can't happen in this time period. That's the problem with drugs that increase the QT interval. And this is additive effects. But that's what happens. That's its mechanism. Here's why that is some desirable effects that happen because of it. Let's do increased contractility first. Let's work our way back up. Increased contractility. We're giving that ventricle a whole lot of time to get together on the same page and get a good contraction in. So we can have increased contractility of the heart, which could inhibit that ventricular fibrillation that's happening. So if we have a reentrant tachycardia that's happening in the ventricles, and we're saying, hold on, let's just spread out our time, and nothing else can happen in this time period, we can't have another beat, then that's going to allow the ventricles to get back on the same page together. So this could be a good thing. But when it comes to defibrillation, it will have a reduced defibrillation energy requirement, so you don't have to shock a patient as much. So it's good to know, and with sodium channel blockers, it increased the amount that you had to. But in this case, if you have a patient who's on a potassium channel blocker, it's not going to take as hard of a jolt because already the ventricles are wanting to stay together. We have that long action potential there so that they can respond together and have a good contraction. And therefore, it doesn't require as much energy. You know how, like on Grays, they keep like increasing how much energy is going to go through those paddles. Patient on potassium channel blocker is not going to take as much because we have those longer action potentials that the whole ventricle gets a chance to get on the same page to have a good contraction. Now the toxicity here is torsades. The more we draw out that action potential, that QT prolongation that happens, there's more of a chance that that next beat's not going to happen correctly, that we're drawing it out too much. So it increases the action potential duration, especially if that heart rate is slow. And then we lead to torsades, which can kill someone in a minute. That was the twisting of points. So we've spread out the action potential too much. You've got to monitor QT intervals on a patient that's taking potassium or taking a potassium channel blocker.
Would these kind of drugs not be used like chronically? Will it just be used for like acute?
That's a good question. She said, do we just use these acutely while we can monitor them, or do we send them home on them? We will send a patient home on these drugs, but they are on some sort of REAMS type monitoring so that only certain pharmacies can fill them, only certain doctors can write for them. You have to have certain tests run at certain intervals in order to continue a prescription for them. It's a great question. But they will be on telemetry while they are in the hospital when we're using it for the first time, and they will be monitored for a few days before we were to send them home on them. So potassium channel blockers, no joke. All right, next up, calcium channel blockers. We say calcium channel blockers, but we only mean two of them, okay? We only mean verapamil and diltiazem. Are those the dihydropyridines or the non-dihydropyridines? Non, right? They don't end in -pine. So just verapamil and diltiazem. If I give you a test question and you think, ooh, it needs to be a calcium channel blocker, and I have nifedipine listed, guess what? It's not the answer, okay? Nifedipine would not be the answer. We are only talking about verapamil and diltiazem. Why? These are the only ones that have direct cardiovascular effects, and they're going to strengthen that AV node. The beta blockers and calcium channel blockers are the effects that we're looking for at the AV node here. So the main effect is that we are strengthening that AV nodal block. Now, that is a mechanism, but that is also a toxicity, because sometimes, I mentioned to you beta blockers and calcium channel blockers, I think of them as bouncers. At the AV node, sometimes they get a little too proud and don't let anything through. And that is that is called a block. So that means the action potential is not propagating through. That is a problem, right? So we're wanting to slow down the action potentials there, but we don't want to completely block it. And sometimes these drugs will do that. They're overzealous bouncers. Yeah, we'll call them that. Let's see. AV nodal refractoriness increases. So again, it takes just a little bit longer for that action potential to get through. And that PR interval increases. What was the PR interval? Yeah, it was that delay at the AV node. So that makes sense, right? We're trying to slow down what's going through the AV node. And so it would increase that PR interval. So there's more of a delay there. The major effects of these calcium channel blockers are in slow tissue. I didn't reiterate slow tissue here, but slow tissue is SA and AV nodes versus in the ventricular conducting system, like the Purkinje fibers and the bundle of His and the ventricular muscles, or all muscles actually, atrial and ventricular. Those are very fast tissues. Like they propagate the action potential and contract extremely quickly. Your SA and your AV node, they're the leaders, right? They can't make knee-jerk reactions. They have to set a pace for the whole heart. So they are comparatively called slow tissue. Now, are they slow? No. It's our heart, right? It's fast. Everything's happening fast. But comparatively, your SA and your AV nodal tissue are called slow tissue, and that's where we have the majority of the effects of calcium channel blockers. Let's see. Secondary use is to slow ventricular rate in atrial flutter or fibrillation. Adverse effects you probably already know because we use them for hypertension, right? So of course it would cause hypotension. That's just going to be worse if we start adding it with other drugs. So interactions here are something to think about. But then it can cause that SA nodal bradycardia, so we slow it down too much, or we slow the AV node so much that then there's action potentials aren't getting through it as quickly as they should. Calcium channel blockers with the beta blocker, knowing that they both are going to be the bouncer at the AV node, if you put them both together, you're getting a little bit risky there by having two drugs that are really watching the AV node. So we're careful when those are combined. Not that you can't do it, just have to be very careful. All right, individual antiarrhythmics. We're not going to hop in too deep to these, but I want to give you a couple of things for overview. Renee.
So let's say your patient does get an AV nodal block. Mm-hmm. What would we then do?
So we're going to stop the drug, right? If we can get it out of the system quickly. We will probably have to do a cardioversion to get the heart beating back again. But nodal blocks are scary, and both SA and AV nodal. There's different grades of blocks, so hopefully it would be a smaller block and not one that's not letting anything through. But it would require some quick action. Audrey?
Since we use beta blockers and calcium channel blockers for anti-hypertension agents, are those like lower doses than what we would use for anti-arrhythmia agents, or?
So still going to be monitoring them. Probably what you're using for hypertension would be a dihydropyridine, correct? Or if you're nifedipine, you can use rapamycin and diltiazem too. But it would be a special circumstance that we were using both. Like they've had a heart attack and they're African American. Like I could think of a situation where I would want to use both, but it would be monitored very closely for an AV nodal block. All right, so let's look at the learning objectives. This is going to be where the bulk of time is spent for exam questions. So I want to make sure that you understand what we're doing. So I'm only going to ask you generic names, not brand name. And you need to know which class it's in Again, that's the Vaughan Williams class, as well as what its mechanism of action is. Now, when it comes to class 1, I told you that there are subcategories, so you will need to know how those are different when it comes to ventricular myocytes. They act similarly on the atria, but when it comes to the ventricles, they have different mechanisms, so you'll need to differentiate that. I use some drug tables that are in, actually it's not our main textbook, it's a different textbook, which I do reference, but I put them here for you because I think it just summarizes everything very well. That does not mean that I'm going to ask you to memorize every single detail on those charts, but I do want you to know select clinical applications. This is mostly if it's going to treat atrial or ventricular arrhythmias, is what I'm wanting you to think through here. I want you to know some serious adverse effects because those are the ones you've really got to watch out for. It might be rare, but they're life-threatening, but also some common ones. What are you going to counsel patients on? There are some contraindications that I want you to know. And then the therapeutic considerations are kind of those little clinical pearls that, this drug is the only drug in the world that causes this weird adverse effect. You just have to know it. But I will point these out during lecture so that you're not memorizing the entire table. But when you need to refer back to something on antiarrhythmics, I think you'll find these tables really helpful. Everything else, let's see, beta blockers. Again, I'm not going to spend just a ton of time on beta blockers. You need to know them, but I think you get it in a lot of different places. So I'd rather spend time on the sodium channel blockers and potassium channel blockers because you're not going to see those in other sections like you will beta blockers and calcium channel blockers. But a little bit on beta blockers. We'll zoom into amiodarone. Amiodarone is one of those drugs that we put it in class 3, but it fits into all 4. It has properties of all 4 categories. So if I ask you which class it is, the answer is 3, but it actually has properties of all 4 of the categories. But we use it a lot, and so I want you to know a lot about it. It certainly is an interesting drug. Adenosine is one of those that doesn't fit, and digoxin is another that doesn't fit nicely into those tables that I'm providing you. And then we'll talk a little bit about potassium and how both high and low potassium interferes with the heart. Now this table, I do actually want you to know every single plus sign, and if it's 2 arrows or 3 arrows, if it's 2 plus signs or just 1 plus sign. I'm kidding. Totally kidding. Come on, stick with me, guys. We only have 3 more minutes left. No. So I am demonstrating tachycardia. Everyone has tachycardia at this point, right? No, this is a table for your reference. I think it makes sense once you start learning the drugs. You're like, oh yeah, that totally makes sense that the PR interval would increase in this situation because I know this is the mechanism. It's going to affect the AV node, therefore PR interval. So if you were to go down PR interval and look at the plus signs, it's probably going to be on beta blockers, calcium channel blockers, and digoxin. That was the one that we haven't talked about yet. So I think this table makes sense as you go through it and think through the mechanism. This is not one to memorize. And let me clarify for those who are watching on video and are not in class, I was totally kidding. You do not have to know the number of arrows versus a number of plus signs. But if you understand the mechanism, this is something that you can come back to at the end of the section and say, oh yeah, that totally makes sense. And just kind of how these link. Definitely not going to ask you half-life, but I think this table is helpful. So for sodium channel blockers, since you're going to lunch, I'm going to leave you with this lovely double quarter pounder from McDonald's, because this is going to be the way that you can memorize the subclasses of the sodium channel blockers. They fit in really nicely to this cheeseburger. So I'm leaving you with that. We'll hop in on Wednesday to talk about the specific drugs. See you then.